For our third and last speaker here in this session, we have Professor Kieran O'Sullivan joining us. And Professor O'Sullivan comes to us as a recent expat here in the Doha community, working as a lead physiotherapist at Aspetar with the sports spinal group there. And but prior to that, Professor O'Sullivan was working 12 years ago, began lecturing in the University of Limerick. And about 3 years after that, then got recognized as a specialty therapist through the physiotherapy group in Ireland. So if you look on the internet right now at Professor O'Sullivan's role and research with regards to low back pain, persistent pain, that's certainly going to be a nice bridge for us here this afternoon for this discussion, and looking at hopefully how that links up here with what we're going to see with opiate addiction.
Thanks. Good afternoon, everybody. First of all, thanks to the committee for inviting me here this afternoon. As has been mentioned, I'm from Ireland, and we like speaking very, very quickly. So if I start to take off and you're starting to drift, start waving like crazy. The first thing to highlight is there's a distinct feeling that I'm a fraud being here today, because if somebody wants to ask me questions about pharmacology, I'm in deep trouble. I know a little bit about pain, and so I'm going to talk about our approach to managing people with pain, with a particular emphasis on spinal pain. Today, I guess I'm going to look at, in the lecture, I have a workshop later, has treating pain been a success? So if we look at outcomes for people who develop spinal pain from the 60s, 70s, 80s, and 90s, are your chances of living a meaningful life nowadays better than they were 30 to 40 years ago? Secondly, what are the mechanisms underlying persistent pain? Finally, do the treatments, if you're a person with persistent pain, do the treatments you generally get offered match what we know about persisting pain? And can we do anything about this mismatch? Now, today I'm going to talk about the vast majority of persistent pain. So for example, you can have pain related to multiple sclerosis or cancer or so on, but I'm going to talk about the 90% of pain that is related to what might be broadly called musculoskeletal pain. So the obvious starting point is to show how we haven't been doing very well with pain and disability. So here we've got, this is data from America, but we see this in many countries. This is over the last couple of decades, what's been happening with MRI imaging rates, opioid prescriptions, epidural steroids, injections, and the big costly one, lumbar fusion surgery rates. So you don't need to be an economist to realize that's a big increase in expenditure. This might be justifiable, however, if, for example, people were living a better and more meaningful life. However, that's definitely not what we see. So this scale on the left is not incidence or prevalence, it's the likelihood of being disabled by your condition across three broad groups. So this is musculoskeletal conditions, back and neck pain being the big ones. This is circulatory conditions, hypertension, angina, and this is respiratory conditions, asthma, COPD, and so on. What we see is that if you take somebody in the mid-90s who had hypertension or angina, compared to then, you're now more likely to be able to work and maintain your hobbies and live a full and active life. In contrast, if you were somebody with back pain or neck pain 20 years ago, you are now more likely to be on long-term disability, unable to hold on a job, unable to participate in the things you like doing. Now, sometimes when people see that slope for musculoskeletal conditions, they say, well, you know, nowadays people are more sedentary, their diet isn't as good, they're more likely to be overweight. But if it was that simple, the circulatory conditions should match. So there is something distinctly unhelpful, with the best will in the world, about what we have been doing for musculoskeletal conditions. So I don't ever say this to the health minister in Ireland, but if you were in charge of the health budget and you saw those graphs, who would you say was giving the best value for money, and who would you feel like kind of constraining their expenditure and rewarding? And it's not for the want of trying. So if you look at spinal pain, we've tried lots of different things. We've tried manipulation, we've tried various forms of imaging, lots of exercises, lots of injections, lots and lots of pills, lots of other needles, lots of surgeries. And what we generally see is, if you take any study essentially, they all help a little bit, but no intervention looks like it's particularly effective, particularly in the long term. It might help pain a little bit, it might make a moderate difference in disability. So while some people do benefit, it doesn't seem in any way predictable. And one of the reasons that's becoming, I suppose, more clear is that we have to think about whether pain as an experience is an injury. So for example, most people with back pain will say, I have injured my back, which might be true initially, but they still assume the reason they have pain is that their back, the tissues in their back are still injured. Whereas I would give a contrast between something like back pain and something like spraining your ankle, or in this case, having an injury in your hamstring. So if you think of an athlete who's playing in the Emir Cup final on Friday night, he might experience an injury and tear a muscle in his hamstring. But that is generally an appropriate term. So when you take a picture of his hamstring muscle, it looks very different to a hamstring that isn't injured. In low back pain, that's not really what we see. Even if it happened initially with a lifting injury or a trauma, a motor vehicle accident, the pain is not explained by what we see on the imaging, and the impact it has on their life doesn't correlate either. In fact, back pain has a lot more in common with things like headaches than it does hamstring injury. Now, unless you're very, very healthy people, a good bunch of you here will have had headaches at some point in your life. Can you tell me about some of the triggers that would have, if not in yourself, in other people, would have triggered headaches? Stress. Anything else? Food? Alcohol? Yeah? Sun. Sleep? Lack of sleep? Okay. And if we think about just those examples that you mentioned, there was biological, chemical involvement of alcohol, but even looking at examples like stress and sleep, do you think those kind of things can injure your head? Or at least can cause pain? In other words, we're quite comfortable with the idea that if I came up here and I said, I've got a terrible headache because the kids were up a couple of times last night and I'm really tired and I've got a headache, there'd be a lot of people saying, yeah, I think that's reasonable, I can relate to that. Whereas if I said, my back is killing me because, I didn't sleep well last night, that's something that we're not quite as comfortable with or easy, we don't find it as easy to relate to sometimes. Because sometimes if it's not an injury in your back, there's a perception, well, then you must be imagining it, or there's something psychologically weak about you. So what's the likelihood that there is in back pain issues in the tissues? This is a systematic review looking at the likelihood of having some things that sound scary in your back. So there's all these terms that can sound very medical and very frightening, but essentially they all become more frequent when you get older. So if you take somebody in the prime of their life, I'll pick 40 for no reason at all. If you're at the age of 40, you are rare and unusual if you don't have something called disc degeneration. It is normal. It is like having a little bit of baldness or some wrinkles or some dry skin. It is not a pathology. However, if you're a person aged 40 and you go for an MRI scan, you will be told you have disc degeneration and generally not be told this means you are normal. Okay? Instead, you're left with the lingering impression that this is a defect in your spine which is potentially threatening. All we can say with back pain is that this is data then on people who have pain versus people who don't. And essentially, you are fractionally more likely to have some of the stuff we see on imaging if you have pain. It's a very small percentage. In other words, if I take people here, let's say everybody in that side of the room has back pain, and everybody here doesn't have back pain, loads of people here are going to have pathologies or things that sound like a pathology. The people with back pain, they might or might not. On average, it'll be slightly higher, but it's not easy to discriminate. Whereas members of the public think there's a clear discrimination. A picture of my back will tell me if I have a problem or not. The reason I come back to this is it is generally considered amongst the public that one of the best things you should do in the early days is go and get a good picture of your back. But actually, the more we look at this, it looks like the scan, particularly, first of all, isn't a very good idea. But if you really want to have a bad idea, you should get it done very early. Because the earlier you go for it, the more likely you are to opt for drastic treatments that might not help. Some of the reasons for that, if you were going to take a picture of my ankle 2 days after I've injured it, what would it look like if you took an MRI scan? It would not look very nice. It would look red, hot, swollen, and inflamed. Whereas if you waited a week or two, which is what they'll generally do if you're thinking about surgery, the acute stuff will have settled down and you might see if there's still something meaningful. And our back isn't that different. If you've got an acute injury in your back, it's going to be looking a little nasty in the early few days. But it's actually better management unless there is, again, a medical reason to be worried, like spinal cord compromise, which is very rare. It's much better to wait a few days or weeks, let the acute inflammatory reaction calm down, and then it's still not essential to get a scan, but at least then there'll be less reason to panic. So in terms of issues in the tissues, most people with back pain, through no fault of their own, it's what they've been told, will think if I have back pain, there is something distinctly odd or unusual and unhelpful about my spine. Whereas clearly all the evidence says it's not all about spinal tissues. Equally, I'm not saying they're irrelevant. Your tissues are a source of biological input, and we are all subject to inputs. As you're sitting there, hopefully you're hearing me, but not the humming sound in the background. Hopefully now you can hear a bit more of that background sound. Our body at any given time, whether it's related to light, sound, the sensation of your feet on the ground as you're sitting there, has various inputs. And at certain times, those inputs can become painful, but they're not all dangerous. So any input I get from my back as I'm standing here, I'll have some muscles that might be a bit tense, but that's not necessarily enough to cause pain unless it's modified and magnified. So here we're going to talk about a contentious topic. The topic of pain thresholds. Now, it's always dangerous for a man to talk about pain thresholds because we'll get accused of, basically once you haven't gone through labor, you don't get to talk about pain thresholds sometimes. So we have this vision that, there is a pain threshold up here. So what I'm going to talk about is the idea that generally a traditional tissue injury model is that this is the pressure from my back, the signal from my back. And if I lift something that's very, very heavy, it will hurt and I'll get an inflammatory reaction. And then the idea is that it will heal. And again, this definitely happens. If anybody is in doubt, you can come up and I'll kick you in the shin and we'll demonstrate how you can get this normal tissue injury response. The problem is that while this occurs some of the time, it doesn't explain all pain. There's a couple of reasons. First of all, if you've got a person who walks, they are putting pressure on their spine, but you will get, again, some local response in your muscles and so on, but you don't experience pain. The problem is that some people do things that are not dangerous, like they bend down to their toes, they lift up their kids. These are not dangerous activities. Nobody has ever shown that bending to pick up your kids or swinging a golf club exceeds the ability of your spine to twist and load. Yet there is no doubt that these activities hurt many, many people. Generally, it's not, however, because these activities are so severe that they exceed your pain threshold. It's much more the case that the activities might be provocative, but your pain threshold is dropped a little bit. This can become contentious, however, because if you use that language with a patient, it can sound like they're too sensitive and need to toughen up a little bit. And that's not what we're saying at all. Can you give me some examples, though, of what kind of things, what factors might reduce the cap, might start to bring this biological threshold down? Because we've mentioned some of them already. Flexibility, it could have some influence. It wouldn't be the first one that had jumped to mind, but it can. It probably has an influence. Stress has huge, in two different directions. What would happen with acute stress to this pain threshold? It actually goes up. So if there's a fire alarm here, stress tends to actually boost our pain threshold in the short term, and even if I have a sore leg, I'll manage to get out of the burning building. Persistent stress does a very different thing to our body and really ramps down our pain threshold. What about sleep deprivation? Very, very powerful way to reduce your pain thresholds. What about hormonal factors? If you take a perfectly healthy woman without any pain and you look at her normal menstrual cycle, what's going to happen to pain thresholds? They're going to fluctuate up and down. Is it a coincidence that critical periods in your development of pain are around adolescence, or your transition from having pain in one part of your body to multiple widespread pains such as fibromyalgia and chronic fatigue happens particularly in women around the age of 40 to 50? There's very, very common ways. Alcohol, sustained diabetes are all ways that this pain threshold can be modified. And in fact, we have this idea that you have a certain pain threshold. But I suppose what I'd like us to think about is that on any given month, our pain threshold will naturally vary according to if I'm sleeping well, getting exercise, managing my stress, and living a fulfilling life, my pain threshold will be in a more resilient state. But again, it's important that we don't give people the impression that this means they're too sensitive. So I would like to give a couple of examples of how this is not just chronic pain. So I often discuss with patients how this applies to things like cold sores. Now, what causes cold sores? There's a virus and stress or stuff like that. So I'm going to say kids cause cold sores. So when this boy was born, about a month afterwards, I got a cold sore. My wife says, there's a bloody fear of you. I had bigger problems. The reason is, I hadn't had a cold sore in about 10 years. But I was a little bit, in layman's terms, run down, because I maybe wasn't sleeping very well, or a bit stressed, not exercising. But nobody in the world would have said, oh, he's got one of those psychosomatic cold sores. There's nothing really wrong with him. There would have been an acknowledgement that it's okay to get a cold sore when your body's a bit run down. But what if I got some spinal pain, neck pain, or back pain at that time? In other words, pain, like cardiovascular disease, like cold sores, involves biological triggers, but also your immune system being vulnerable through many of the social factors that were just discussed. Thankfully, when his sister came along, I didn't get the cold sore, so that was a great sigh of relief. So when we think about people with persistent pain, there are probably some parallels with Professor Krupa's model in this, in terms of there are clearly pathoanatomical factors involved in persistent pain, and in the workshop we can discuss those a bit more. In other words, there are things that can be sore in your back and sore in your shoulder that contribute to pain. That is, without a doubt. It's just that it's nowhere near as important as we've been trained to think. There are also some physical things about the way you move and your posture that are relevant and worth looking at. But again, it's nowhere near as important. In fact, these factors combined, which is what most people think about with persistent pain, explain about 15% of the disability we see. What's also very important is lifestyle factors. So for example, sleep, physical activity, and stress, and diet. Psychosocial factors, which you should all be familiar with, are huge drivers of pain sensitivity. These all, through their own different ways, have ways of sensitizing your nervous system. So your pain threshold and related sensations, such as fatigue, are heightened to a remarkable extent. And of course, we don't really understand very well yet how these interact. But we do know, for example, if you have certain genetic markers, you are more likely to have pain. And if you have the same markers and you have a highly stressed family home, your risk is increased further. The challenge here is, I'm a physio. And essentially, when somebody comes to a physiotherapist with pain, what do you expect? A rub, or a crack, and maybe some exercise, maybe some machines. If you go to see a chiropractor, you'll expect a crack. If you go to see a doctor, you might expect medications. And there are limitations to any individual profession's scope of practice. There are legitimate reasons for this. However, one of the key challenges we have is that if you look at 100 people with persistent pain, the exact contributing factors that drive their pain might differ. It might be physical, or it might be psychological, or a mix of these factors. So it's important for clinics who provide pain services to be flexible, to offer a broad range of services, and to try and match those to the needs of their patients. So I would say this is similar to the management of obesity and other chronic diseases, that there's a breadth of factors that are involved, and we need to try and tailor the solutions we can offer people a bit more to their need. Because if all I have is a hammer, all I can see is nails. So when we're discussing pain, try to address whatever issues are involved. It's tempting when a person comes in only wanting to think about pathoanatomical factors like disc bulges and posture to just go along with that. But if there are other factors which are clearly important in that person's pain, it's important to address those. But if you are going to have a more honest conversation with the person, try to ensure that there's a sufficiently strong relationship in terms of empathy and rapport to have that honest conversation. And that mightn't always happen, I'm sure, at the first stage. Patients are usually happy to have the distressing nature of their pain acknowledged. So people are generally very happy to say, this has been a really crap time for me because I have no energy, I'm very sore, and things are starting to fall apart. As long as their pain is not being dismissed or you're not trying to stigmatize them. And then there are times when we're going to have to refer on with that. But again, when we communicate about patients, one of the big challenges we see is being honest in our onward referral notes. What I mean by that is I will often have conversations with doctors where they would tell me, I saw this patient, Kieran, and I'm sending him on to you. There's a lot going on, but particularly he's lost his job now, has a lot of time, no activity, and is really frustrated and doesn't see any hope for the future. And this seems to be a big part of his pain. But then the referral letter will say, please see Kieran, disc degeneration, L5. In other words, doctors and physios and other health professionals, in our communication with patients and about patients, we're not always as honest with them as we probably should be. I'll talk in the workshop about how we'd actually change this, but there's been one randomized controlled trial in Norway, which is showing that compared to another reasonably recommended NICE guideline-based treatment of manual therapy and exercise, this is on the left-hand side a disability scale. So manual therapy and exercise, a kind of a conventional exercise program, helps a bit. And this program, which we call cognitive functional therapy, helps a bit more, and we sustain this at 15 months, and now at 3-year follow-up, we're finding the same. In conclusion, pain is an alarm system. It is a signal to our bodies that something is wrong. And it's often right, same as fatigue, same as thirst. I would imagine there are even parallels with craving. It could be a very useful signal that you should listen to. However, it can often be an inappropriate signal which your body shouldn't pay too much attention to. So the alarm might be triggered by tissue injury, but there's a lot of other potential reasons. Even if it isn't about injury, all pain is real. I don't want anyone to think that if it's not your discs, then in some way your pain isn't as legitimate or as valid. When I hear people talk about my work, they say, oh, you treat backs, because generally we don't get referred people with necks or with elbows and wrist problems. However, we're still treating people, not joints or muscles. And desensitizing the person's alarm system is possible in many ways, and that's where medication has a huge role. However, it's by no means the only solution. I'd like to thank some of the people who do the work when I come to talk. Many of these are in Ireland. We have a website that talks about some of these things. These are some of my international collaborators. And that's all. Thank you very much.
Thank you, Professor O'Sullivan. Got time for a few questions there. If there's anyone in the audience here would have a question. Question in the front here, please.
I have had a total disc replacement in L5S1, and it's been about 10 years.
Mm-hmm.
And I've done very well on the most part. But the injury was so that L4, L5 was also injured, and they replaced the worst one. And so my pain level went from like a 7 down to 2 or 3.
Okay.
So I felt, I still feel very well about it.
Yeah.
But I still, if I do certain activities, reaching, over lifting, then if I'm not careful, I'm out of business for 4 or 5 days.
Okay.
I mean, I just,
You're stuck.
of course, I take Celebrex every day, but I'm off the 2 other pain medications that I had
Previously.
There was 5 years before the accident and the surgery.
Oh.
Is there any way I could address the other disc, the L4, L5 issue successfully in this day and age?
So I guess, first of all, it's good. That sounds like a good outcome from a total disc replacement. It's not representative, so that sounds like a very good improvement, acknowledging you still have some symptoms. And of course, I can't know, obviously, without getting a full history and examination and so on. In terms of, I suppose, the big issue I would say is make sure we're focusing on treating your pain and not the scan. So, for example, it's possible that you could have that same disc bulge 5-10 years' time from now and have little or no pain, or the pain could be much worse. I'll make one broad point about people who do well with surgery and people who don't. So if we look at the predictors of somebody going for knee replacement, hip replacement, spinal surgery, and so on, the people who do best with surgery are people where they say, I've got this one pain, and they'll point to the part that's sore, my knee, my hip, my back. I'm generally in good health, but this bloody thing is holding me back. Now, that's not the words they use, but that's essentially what they're saying. In contrast, if we look at a group of people where they're saying, yeah, I've got this hip problem, I also have this shoulder and this knee and this other thing, and I'm exhausted all the time, and my life is really tough, and I feel crap. It's understandable that they get offered surgery and lots of other treatments like physiotherapy, but it's very difficult to help those because those various pains are indicative of kind of a lack of wellness in their body as a whole. So in terms of the kind of things I would think about dealing with somebody like yourself is I would clarify, first of all, so it's still just the back, for example, and it's the back related to things that load the back. And if it is, then I would look at some physical conditioning to try and reduce the pressure on your back. A common thing would be trying to strengthen your legs so that your back is less provocative. In contrast, and I don't think this is what you're saying, if you were saying, yeah, my back, but also all these other vague sensations and symptoms are appearing and my energy levels are going, I'd be far more reluctant to consider more back-directed treatments. Does that make sense?
It sure does, yes, and that's exactly the way I see it. I'd say it's my last option. If the pain gets to 7 or 8 again, I probably will do surgery again, but as long as I can avoid it, I will.
There's somebody next to you going like this. Yeah. But again, because I don't want, look, again, I'm not a surgeon, but there are people who respond very well to surgery, and there are people who respond terribly. So it's very much about trying to identify the people who are likely to do well. The hard thing is the people who don't respond well to what I offer generally don't respond well to what the psychologist currently offers, or the surgeon, or the pain physician. So partly that's because maybe we're not very good, but also I think it tells us about the complexity of their presentation and their life. And again, I think that probably has parallels with some of the issues around addiction and so on.
Thank you.
Thank you, Kieran. Nice to see someone from Limerick. I lived there for 3 years.
Oh, good.
Kedmila Folti.
Okay.
Allow me to speak Gaelic.
Oh, yeah.
Konastatu.
Tomiraus, come on.
Very good. Yeah. My question, what is the percentage of your patients who come for back pain or whatever you refer for psychology assessment?
Okay.
Thank you.
Can I split it into two, your question, because it's an excellent question.
What is the percentage? Yeah. Sorry.
So the percentage I would like to send and have visit a psychologist is very different from the amount of patients who go to see a psychologist. That's why I'll split it in two. So we have, for example, in Aspetar, a very good psychology department who are willing to work with us. And you can probably imagine some reasons why the people who I think might benefit from seeing a psychologist is smaller than those who end up going to see the psychologist. Now, there are lots of the things I discussed here that people might think are psychological, but they're normal life things. So my sleep is a bit disturbed because I've got a lot on my mind. And sometimes if I don't exercise, my sleep isn't good. So lots of the things around stress and sleep can be dealt with by having a more fulfilling life and being more physically active. But there are clearly times when specific psychological support is indicated. I would say if I could get athletes and patients to be totally open to going to see a psychologist, it would probably be about 25%. As it stands, the amount of people referred is probably closer to 5. Okay? And that wouldn't be that different here to Ireland. Okay? So the proportion of patients I send is pretty small. Yeah, that's all I could say. And I cannot present you with good data showing which improves the outcomes or not. So for example, we don't have good evidence that multidisciplinary physio, doctor, surgeon, psychology outcomes are that much better. It looks like they're about 10% better, but they cost about 50 to 60% more. So there's an argument that you save those for much more complex cases.
Any other questions there from the floor?
There's one at the back.
Okay.
Yeah, well, go for it.
It sounds like there's almost, for physical back pain, it seems like you either see a psychologist or psychiatrist, or you get surgery, or you build up your muscle. How can we tell, or how can anyone tell, whether it's a muscular issue? In other words, your core is just not strong enough, or whether it's actually in the bone part that he describes.
So I'll step back to the first part. I'm talking, of course, here firstly about the bit that you do in a clinic. The elephant in the room, of course, is some of the stuff, again, Professor Krupa mentioned around healthy communities and, you know, keeping people healthy so they don't even present with the back pain.
Exactly.
But once they come in, the key discriminator for us is, does it walk like a duck and quack like a duck? In other words, when somebody points to one part of their back and they can say quite clearly, this hurts, and when I go over here, it's better.
Yep.
And yeah, that hurts, and this is better. It's a very, you know, it's very mechanically based. Then we pay a lot of attention to the local back. However, a lot of the time, people with back pain don't say that. They'll say, well, I walked for 20 minutes Monday and it hurt, you know, terribly. And Wednesday did the same and it didn't. That's not typically mechanical back pain. Or it was very bad in April for no reason and May was fine. And the no reason, generally, when you delve into it, it was, oh yeah, well actually, my husband was away that month and then because of that, I had no time for exercise or normal life. So if it is very much related to back movement, loading and posture, and there are clear easing factors related to that, you do get much better bang for your buck from treatment directed at your back. Mm-hmm. It's just that, I'm not ruling that out at all, it's just that it seems to be that everybody gets pushed into that treatment, whereas sometimes we just need to step back and look at that person's life as a whole.
Thank you, Professor. We've got,
I have a workshop after this as well, but I don't know.
Yes, we've got a workship coming up here right away.
In terms of time.
Thank you very much. Pain is an important element in addiction work, really. Do you hear me?
Just barely, is it? Is it on?
Hello?
Ah, yes.
Yeah. What we try to do is to have the patient, sometimes inpatient, in a pain clinic. We are lucky to have St. Thomas Pain Clinic, which have 200 employees and a world-leading center. And we try our best in order to find the solution for pain, in order to continue the treatment. So what is the size of your pain clinic which is connected to the center?
You mean as an inpatient facility?
Yeah.
Oh, yeah. So we don't have any inpatient facility as it stands at the moment. And that probably reflects the relative health of the patients we're seeing in Aspetar at the moment. That could change as the center expands. So for example, at the moment, we are essentially seeing athletes and a small number of other people. So we are, for example, whereas if I contrast that with in Limerick where I was working, I was dealing with a lot of people who were on long-term disability, long-term unemployment, and a bigger mix of socioeconomic factors where there was a much more complex mix. I think there are times when, again, patients need a lot more support, whether that's inpatient or not. But even if we have that facility, on a public health basis, they'll only ever be a small part of the back pain or spinal pain service. So there'll be a small proportion, even if it's a very costly proportion.
I have to jump in there, Professor, if that's okay. We'll carry it into his workshop here shortly. I think all the questions from the floor is a great example there of how we can certainly more work to do with interdisciplinary and linking up things that'll be from the different disciplines. So thank you, Professor. I have one quick announcement.